When we look at the heart, it's involved in two different circuits, the pulmonary circuit and the systemic circuit. The pulmonary circuit is the flow of blood between the heart and the lungs. So from the heart to the lungs, from the lungs to the heart, that's pulmonary circuit. The other circuit is the systemic circuit running between the heart and the body. So from the body to the heart, from the heart to the body. So those two different sets of blood flow are going on all the time. And what you can see is that half of each of those circuits consists of oxygen-rich blood, and half of each of those circuits consists of oxygen-poor blood. Let's trace the flow of blood through the heart. This is perhaps the most important part of this topic, is where does the blood go and how does it get there? So the blood is going to come from the body and might come from, let's say, below the heart through here, the inferior vena cava. If it's coming from above the heart and the body, it's going to enter through the superior vena cava. And right here at the back of the right atrium is where they plug in. So returning blood from above the heart, superior, returning blood from below the heart, inferior vena cava. So that dumps the blood here into the right atrium. Now this might look like it's on your left, but remember, your left and the patient's left are not the same thing. So always remember your anatomical position. So blood is here in the right atrium. The job of the right atrium is to pump the blood to the next chamber, the right ventricle. So when it contracts, it will push the blood from here through this valve called the tricuspid valve into the right ventricle. Now that was only a matter of a couple of inches, so the musculature of the right atrium is relatively thin. Now every time we go from one place in the heart to another, we're going to go through a valve, and the job of that is to ensure one-way flow of blood. We don't want blood to go backwards, so when the blood comes from the right atrium through the tricuspid valve into the right ventricle, the blood is going through. When the right ventricle contracts, the blood's going to turn around and start trying to come back up into the right atrium again. But when it tries to go in reverse, it will catch those valves and slam them shut. So the attempt of blood to go backwards through this valve actually closes it. Sort of like a door. A door only opens in one direction, and if you bump into it the other direction, you did nothing more than close the door. The right ventricle has to push blood a lot farther. It actually has to push it out to the lungs and back to the heart again. So the musculature of this chamber is much more than that of the right atrium. Blood is going to leave the right ventricle here through a pulmonary valve. Sometimes you see this referred to as a semilunar valve. So the pulmonary valve here ensures that once blood leaves the right ventricle and goes into the pulmonary trunk and pulmonary arteries, that it doesn't come backwards again. We don't want blood to flow back into the right ventricle when it relaxes for the next contraction. So blood flows out here, and it's oxygen poor at this point. It flows out to the lungs via the left and right pulmonary artery. Goes out to the lungs, gets oxygenated, comes back into the pulmonary veins. And here we see the left pulmonary veins, and over here we'd be coming in from the right lung, and those are going to plug into the left atrium. The job of the left atrium is to push that blood to the next chamber, the left ventricle, and so again, that's only a couple of inches, just like it was with the right atrium, so thin musculature there. We go through another valve. This one's called the bicuspid valve, sometimes labeled as the mitral valve. I'm old-fashioned, and I like the word bicuspid because that keeps us with the same kind of terminology that we were using with the tricuspid. So the difference between these two is, as their name suggests, tri means three, so it would have three flaps. Bi means two, so it would have two flaps. So it's a two-flap valve or a three-flap valve, and we'll see those flaps here in just a minute. So the blood is in the left ventricle. And the job of the left ventricle is to pump that blood out to the body, all the way to the fingers, all the way to the toes, and all the way back up to the heart again. That is a much farther distance than any of the other chambers have had to push their blood yet. So as you might expect, the musculature of the left ventricle is much more significant than that of any of the other chambers. It makes sense. You need a bigger, stronger muscle to push that blood farther. When the blood enters exits the left ventricle, it's going to go through the aortic valve, found right here at the top of the left ventricle, and then it's going to go up into the aorta and out to the rest of the body from there. Now, one thing we need to point out with these large valves, we find with both the bicuspid and tricuspid valves, and that is that the chordae tendineae are here. So these little straps, and they go down and anchor to the bottom of the ventricle to some special little muscles there called papillary muscles. But what those are for is to ensure that blood doesn't go backwards. So when the valve closes, it makes sure that the valve doesn't pop open backwards. If you put too much pressure on a valve, in theory, it could open up in reverse and then allow blood to go the wrong way and actually interfere with the proper normal direction of blood flow. But these chordae tendineae ensure that the valve can close, but it can go no farther. If we were in the classroom, we would dissect an actual heart. I will do that in a later video, and I will make sure and point out the sturdiness of the chordae tendineae. They look like they're pretty small and insignificant, but they are very, very sturdy structures. Because the heart puts a lot of pressure on those valves, we don't want anything to easily rip loose and then cause problems. So that was the flow of blood through the heart. In the aorta, it's going to branch off into other arteries. So the aorta is the largest artery of the body. Those arteries will branch off into arterioles. Arterioles will connect up with capillaries. Capillaries will connect to venules. Venules will connect to veins. And veins will all lead back to the vena cava. So that's the flow of blood through the body. And we'll revisit those blood vessels and what they do when we get to the next chapter, which will be blood vessels. And we'll review what those functions are. But just real quick, let's go through this process. And don't try to think of this as this massive maze of blood flowing everywhere. Make it a step 1, then step 2, then step 3 process. So step 1 was vena cava. 2 was right atrium. 3, tricuspid valve. 4, right ventricle. 5, pulmonary valve. 6, pulmonary arteries. 7, lungs. 8, pulmonary veins. 9, left atrium. 10, bicuspid valve. 11, left ventricle. 12, aortic valve. 13, aorta. 14, arteries. 15, arterioles. 16, capillaries. 17, venules. 18, veins. So technically there's an 18-step process of this blood flow through the cardiovascular system. Mostly what we're looking at here today is the flow through the heart, but just keep in mind it has multiple steps outside of the heart. So after just going through that list a couple of times, it will start to click with you and hopefully start making sense. Just remember your left and your right here is opposite your perspective. We mentioned the valves, and we talked about the tricuspid and the bicuspid being 2 flaps or 3 flaps. So here we see the drawing and the actual photograph of a real heart. The tricuspid has the 1, 2, 3 flaps. The bicuspid has 1, 2 flaps. When we look at the aortic valve and the pulmonary valve, those other 2 main valves in the heart there, we see that they were also 3 flap valves. So for whatever reason, 3 flap valves seems to be the standard. The bicuspid just had a little bit different structure. Sometimes you might see these referred to, the tricuspid and bicuspid, as atrioventricular valves, or a valve between an atrium and a ventricle. Here are those chordae tendineae that I mentioned along with the papillary muscle. So looking from this perspective, it does start to look a little bit sturdier. In real life, it doesn't look that sturdy, but again, it is quite. When we look at the slice through this real heart here on the right, what we see is another reminder of the difference in thickness of the chambers of the heart. So both atria pretty thin walled. The right ventricle gets a lot thicker, but look at the left ventricle. It's perhaps 4 times as thick and muscular as the right ventricle was, because again it had to push the blood so much farther. So most of the mass of heart muscle in the heart actually is found in the left ventricle. Here's another perspective to look at that again. The left and right ventricle walls, a great deal of difference there. When we talk about cardiac muscle, it is in some ways quite similar to skeletal muscle. Skeletal muscle is striated, as is cardiac muscle. You can see the little small stripes in there. So to some degree, appearance is a little bit similar. What you'll find though with cardiac muscle is it's not quite as neatly organized in perfect straight lines. There's a little bit of zigging back and forth. But a real key difference between the two is the presence of gap junctions in cardiac muscle that we would not find in skeletal muscle. The point of the gap junctions is to communicate between cells, and this ensures that the heart can contract in the right order. We're going to get into the order of contraction here in a little bit, but the atria contract first, then the ventricles contract. So atria, ventricles, atria, ventricles. But within the atria, you start at a certain point and end at the opposite side, just like you would in the ventricles. So the entire atrium is not contracting at exactly the same time. The entire ventricle is not contracting necessarily at the same time as the other cells within that particular chamber. So what happens is this gap junction allows one cell to communicate with the cell next to it. If a signal originated in cell 1, this ensures that to get to cell 5, you had to go from 1 to 2, 3, 4, and then 5, and couldn't skip straight to 5. This makes sure that the heart contracts in a organized, rhythmic fashion so that the blood actually gets squeezed out. And we'll look at how the chambers contract here in a little bit, and hopefully that will make more sense. This is a brief list of differences between skeletal muscle and cardiac muscle. You'll see there's a fair number of similarities, but also some differences. So just take a look at that, and you can appreciate some of those differences. Let's talk about what makes the heart contract properly. The heart is an electrical pump, so what we have here is a diagram of the wiring of the pump. Always useful when you're trying to understand electrical systems is to have the electrical map in front of you. So what ensures that the atria contract, then the ventricles contract, and everything contracts in the right order or sequence are pacemakers. So at step 1 here we have the sinoatrial or SA node, and this is known as the pacemaker node of the heart. When the SA node receives a signal from the nervous system, it sends a signal out, and this sets the pace for the rest of the heart. So it's called the pacemaker node because it sets the pattern for everything else. You'll notice here it's coming in at the top of the right atrium, and that electrical signal then passes from the top of the right atrium throughout the entire right atrium, which means it starts contracting at the top, and as the further the signal goes, the further the contraction goes. So start contracting from the top and work your way to the bottom. That signal is also going straight across to the left atrium, so technically the right atrium starts to contract just a little bit before the left atrium does, but in general both atria are contracting before the ventricles start to contract. And that's important because they can't both be pushing at the same time. If they're both pushing at the same time, the ventricles will push harder than the atria could, and you wouldn't get anywhere. The atria wouldn't be able to push the blood through the valves because there would be too much back pressure. So the atria really are going to complete their contractions before the ventricles get started contracting. Because they got the signal first, that helps. That signal, as it's passing through the right atrium, goes towards the bottom of the right atrium, and what you see there is the atrioventricular, or AV node. The AV node picks up the electrical current when it reaches the bottom of the right atrium. This is the conduit from the atria to the ventricles. So this ensured again that the atria was mostly finished contracting before you even think about sending the signal on to the rest of the heart. And that takes about 1/10 of a second for that current to get there, meaning it takes about that long for the atria to seriously get contracting. The AV node takes that signal and passes it down the middle of the heart here, called the atrioventricular bundle, and is passing down through that middle layer of muscle separating the left and right ventricle. So as that muscle receives the current, it starts to contract. And so what happens is the middle of the ventricles starts to contract before the outer edges. So if you take your hand and have it wide open and flat, palms out, and start to make a fist, and watch your hand make a fist in slow motion. And that's the way those ventricles are contracting. They start contracting along really the palm side, and then the fingers start to fold around. So we would see that here. Here would be the palm of the heart. It would start to contract. And as that signal travels around, it finally gets over here. And this part of the heart contracts when it gets the signal. This is the fingers folding around. And what that does is it pretty much squeezes the ventricle in a circular fashion, taking all that blood and sending it up towards, in this case, from the right ventricle, the pulmonary trunk and pulmonary arteries. If we're over here in the left ventricle, we would be pushing it up towards the aortic valve and aorta. So middle contracts, then outer edges contract. So that's the sequence of electrical current passing through the heart. So we said the SA node was the pacemaker. The AV node carried the signal on down to the ventricles. And if we look here at the wiring where it's coming from, we have the parasympathetic nerves coming into the SA and AV nodes. We have sympathetic nerves, remember those are the life or death, the fight or flight nerves, coming in on their own set of wiring, and they connect to the SA node and the AV node, but they also connect down directly to the ventricles as well. And this is significant because the parasympathetic, the resting and digesting system, is mostly responsible for slowing the heart rate. The sympathetic, the life or death system, is more responsible for speeding up heart rate, but it will not slow down the heart rate. This explains why it takes so little time for your heart rate to go up when you're startled or scared, and so long for it to go back down. The sympathetic system, we said, was the fight or flight, the instant response or die system. And so it instantly activates not only the atria to contract, but it directly starts the ventricle contraction at the AV node, and it goes down to the bottom of the ventricles and shocks it there as well. So the entire heart, at every possible point, is stimulated. To slow down the heart rate, the parasympathetic system has to take over. And remember that it takes a while to get the sympathetic turned off and get things slowed down. So instantly the entire heart was stimulated, but then we go back to the SA node and the AV node and try to cancel that out and slow it down. But that takes several minutes. So instantly raising, minutes to lower. That's just how it works. It's better to overreact in speeding up and underreact in slowing down than it is to fail to speed up in time or to slow down too quickly before you truly dealt with that life-threatening situation. We can measure the electrical current of the heart as it passes through those different parts, and then that gives us an EKG readout. Now, we say EKG even though the American English spelling is ECG. So an electrocardiogram. EKG is the British spelling. And probably we use the EKG vernacular far more often than ECG. Just understand it's the same thing. Are you using the British spelling or the American spelling? So what we see here in this EKG readout is we have P waves, QRS series, T waves, and then we have segments going from P to R, Q to T, S to T, and really this is just measuring electrical current in different parts of the heart. And if we get this particular readout, then everything is working properly. So let's look at how that really works in the heart. The P wave is caused by the arrival of electrical current at the SA node, and it's starting to go through the atria. So really the P wave is when atrial contraction starts. And there's an increase in current there because there had been no current to speak of, and now that sudden burst of current coming in on the SA node registers as the P wave. The gap between the P wave and the QRS sequence, we see right here, that's when the atria are finishing their contraction and they're starting to have a little bit of a relaxation process. Then down here at step 3 we get to the QRS series, and this is when the electrical current is traveling down the middle of the ventricles, starting that ventricular contraction at the quote-unquote palm area. The gap or space between the S and the beginning of the T wave is when ventricular contraction is finishing. The T wave is when the ventricles start to relax and reset their electrical signaling. And then the green line here going on out the rest of the way until we get to the next P wave is as the ventricles are completely resetting themselves and getting ready for another series. So let's go back and go through that a little bit quicker here. P wave, we start atrial contraction. The P to Q distance here is when we finish atrial contraction. QRS is starting ventricular contraction. The gap between S and T is finishing ventricular contraction. The T wave is the beginning of the reset of the ventricles. And the space between the T and the next P is the complete resetting of the ventricles. And all of those processes happen very quickly. As you would know, the heart beats perhaps if you're resting around, let's say, 60 to 70 beats per minute would be a nice resting heart rate probably. And so that means that roughly once per second the heart is going through this entire process. So there's a lot of electrical signaling going back and forth, charging, recharging, setting, resetting, and all of that happens with a few little breaks in between in under a second. We could measure that electrical current by attaching leads around the body. In this particular manner, here's a little baby getting that done. It looks pretty happy considering all the stuff that has stuck all over. And that's just going to give us that readout. So what we want to see on that EKG monitor is this. So if we look here, we have our P, Q, R, S, T, P, Q, R, S, T, P, Q, R, S, T, over and over again. Everything's nice and evenly spaced out. Everything is there, all the waves, all the spaces, everything is proper and present there. That's normal sinus rhythm, or normal heart contraction. That's what we want to see. Occasionally, things go sideways. So in this case, the SA node is non-functional. Remember, that was the pacemaker node at the top of the right atrium. So if it's not working, then you don't get that burst of electricity passing through the atria and giving you a P wave. So in that EKG readout, you would see no P's. So if we start here, we would have Q, R, S, T, Q, R, S, T, QRST, and no P waves right here at the beginning of each of these to designate that the SA node was signaling. This is going to negatively impact atrial contraction somewhat, but the more important thing that happens here is it slows down the heart. If the SA node isn't setting the speed, it isn't setting the heart rate, the AV node will take over and do that, but it does so at a slower rate. So instead of that, let's say 60 to 70 beats per minute, now we're looking at 40 to 60 beats per minute. So if you decrease the heart rate, you have decreased cardiac output. That is how much blood is actually being supplied to the body, which in turn tells you how much oxygen is being supplied to the body. So someone with what we call here this junctional rhythm probably is going to feel fairly weak because they don't have the good solid blood supply and the good oxygen supply that they really need because their heart is working a little too slow. So that's an SA node or pacemaker node dysfunction. Here's a different kind of scenario here. In this case, the SA node is working fine, but the AV node, remember that was the one that was supposed to pick up the signal from the atria and send it down to the ventricles, is only working about half the time. So if we follow this tracing here, we have our P, Q, R, S, T, P, P, Q, R, S, T, P, P, Q, R, S, T, P. So we have 2 P's for every QRST. So that really means that AV node is only sending every other signal. So that means that we normally would have seen another QRST in between each one of those we actually see. So 2 P's for every contraction of the heart. So the atria might be working at perhaps a normal speed and the ventricles are running behind schedule and only contracting every other time. This is going to cause some congestion in the heart. The atria are trying to contract, but they don't have anywhere to send their blood because the ventricles haven't emptied the blood from last time yet. And so that would probably lead to a lot of strain on the atria. Ventricular fibrillation, or VFib. This occurs if you've had some sort of major electrical dysfunction. Maybe you got zapped by an electrical outlet and not just something that buzzed your finger and made it tingle for a few minutes, but the sort of thing that actually perhaps knocks you on your back and makes you feel really wiped out and weak and just unable to move for a little while. Or you've had a major heart attack, which is going to also mess up the electrical current for a while. So we're not seeing any definable P, Q, R, S, T anything. It's just basically sitting here, and as the name suggests, it's fibrillating, or it's sort of twitching in place, but doesn't have any useful contraction. If this doesn't get cleared up very quickly, you will die. So if we back up here and look at the junctional rhythm, yes, the heart rate was low, but not necessarily immediately fatal. Second-degree heart block, yes, we have congestion in the heart with blood. Things aren't timed properly, but it's probably not immediately fatal. This one here, if it doesn't get fixed and fixed right now, it's going to be life-threatening because, again, the heart's not actually pumping, it's just quivering. So in those problems previously here with these rhythm irregularities, you can get a pacemaker put in, which will help to make sure that those missing pieces actually get added to the sequence. And so they'll add electrical current when it's not otherwise appropriately there to fix these rhythm issues. For ventricular fibrillation, just the idea of a pacemaker isn't going to do the trick here. What you have to do is you have to hit the heart with a massive dose of electrical shock, again in this case, to try to reset it. So the electrical shock you experienced, perhaps, was enough to disorganize the signaling, but a perhaps bigger shock, actually not perhaps, definitely a bigger shock when the defibrillator comes along, is going to try to wipe out that electrical current, sort of like a clean slate, and give the heart a chance to start over from scratch. So you hit it with enough voltage that it just clears the whole system, and then the hope is that things restart from the SA node, the AV node, and everything lines up again after that. And in a reasonable number of cases, that sort of approach would work. Depending on what the underlying problems are, it may be a temporary solution. So sometimes you have to shock a person multiple times back into rhythm again. And in that case, there's probably some big kind of problem there that is not going to get better on its own. But in the more minor irregularities of heart rhythm, those built-in pacemakers are pretty effective. They're actually building pacemakers now with defibrillators built in. So if it detects this sort of thing, or no heartbeat at all, or something like that, it can go ahead and shock to get the system going again. And this is nowhere near the strength that you would see with the defibrillator paddles or pads, but it certainly can fix a rhythm that is a little out. Go ahead and zap it back into place. And any kind of attempt at this point, even if it's not a super high voltage, is still going to hopefully be useful. So that's sort of an emergency automatic treatment built into some of those these days. Probably much more advanced over what was even available 10 years ago. Because the heart is moving a lot of blood and we have all these valves opening and closing, you are going to hear some noise. So if you go to the doctor and they listen to your heart, you'll notice that they put the stethoscope on the chest in a particular spot, listen for a minute, and then move it a few inches and listen again. And they probably do this a couple of times. What they're doing is they're trying to listen for all the different valves to make sure that they are closing like they should. So you can see here on this image where to listen for aortic valve, tricuspid, bicuspid, pulmonary valve function. And none of them are right on top of the valve itself. That's because the heart is such a noisy thing that you need to back off a little bit so you can hear it a little bit more clearly. And getting off to those four corners helps you to hear only what's coming from that corner and gets away from some of the other noise and sound. Now you'll notice here that it's very specific. Aortic valve sounds heard in the second intercostal space at the right sternal margin. So that's fancy speak for going to the right side edge of the sternum, going down to the second rib, and then looking at the space between it. Now, that's a pretty small spot. But what you might notice if you're paying attention is they might have the stethoscope in place and then just move it a fraction of an inch and listen again. So what they're doing is just moving it around by trial and error until they hear what they're looking for. Once you get a little practice with this, you'll get pretty close, but you still occasionally have to do a little bit of wiggling to get in exactly the right spot. The doctor might also listen to the back of the chest as well, and what they're doing is listening to the same sounds on the back side in certain spots to get another angle at it. They can also be listening to your breathing at the same time, but most of what they're listening for here is for appropriate heart sounds. I mentioned cardiac output already, and that's really how much blood is the heart moving through the body. So if we look at the formula here at the bottom, cardiac output equals stroke volume times heart rate. Stroke volume is how much blood is being pushed with each contraction of that chamber. Heart rate is how quickly is the chamber contracting and relaxing. So if we look at how do we increase cardiac output, we actually have to go back up the system and look at heart rate by itself, stroke volume by itself, and what's going on. I'm quite confident you can follow this flow chart in reverse, but let's just do that real quickly here. So if we go up this side, if we want to increase cardiac output, we could increase heart rate. To increase heart rate, we would increase sympathetic activity. That was the stimulatory effect of the fight or flight system. We would decrease parasympathetic activity. That was what was going to slow down the heart. So if we turn on the sympathetic function more, that in turn turns off the parasympathetic, so it's a 2-for-1 special. What would increase life or death system functionality would be exercise by demanding more blood flow, being afraid, being stressed, or a drop in blood pressure. So any of those things could come down here and kick up the sympathetic activity, turn down parasympathetic, which would then increase heart rate. That would increase cardiac output. On the other side here, if we want to increase stroke volume, we can look at some of these formulas here, and basically it gets complicated, but you can do that by exercise, increasing skeletal muscle use, increasing breathing rate with respiratory pump. You can increase the ventricular filling time by slowing down the heart rate. The longer you give the ventricle time to fill, the more full it becomes, which means you get more blood output. We can also look at some hormonal things like epinephrine, calcium levels, things like that, that change the heart muscle function, which would eventually increase stroke volume. So if we increase either stroke volume or heart rate, cardiac output goes up. If we increase both of them at the same time, that increases cardiac output significantly. So if the heart's beating faster and you have greater blood flow into it in the first place over here on this side, then you'll definitely get a significant increase in cardiac output. If you think about the blood flow through the heart, it came down from the top. It went down the right side, up across the middle, back in on the top left, down the left side, back up across the middle to the aorta and back out. So it's a very, as you can see here at the end of this process, it's a very twisting and turning and convoluted route back and forth. So why is it that blood flow is so convoluted through the heart? Going up and down and left and right and all of that. And that goes back to the original development of the heart. So what we see here at day 20 during embryonic and fetal development. So this is 20 days after the egg was fertilized. We have these contractile tubes starting to fuse together. So this is a embryonic heart, if you will. So basically just two tubes next to each other that are pumping to some degree, and they start to fuse together. Then after they're fused together, just 2 days later, the overall structure starts to visibly pump. So at day 22, roughly, you can actually see, with the right kind of imaging, you actually see the heart actually beating away in there. But it's what we call a tubular heart. So it's starting to have some enlargements where it's fusing together, but it's still two tubes linked together at this point. Day 24, so even 2 days farther along here, those tubes start to fold. Day 28, they're folding and rolling around on themselves even more. Day 35, it's finished up. So that convoluted path comes from the two tubes that started rolling and folding back and forth on themselves. And the eventual folding ends up in the path that it has. So really, adult direction of blood flow through the heart is a result of how the heart fused together and folded back and forth on itself. But that path is simply following where the tubes were to start with. There are a number of problems that can occur in the development of the heart process. As those tubes are fusing together, they have to fuse together just right. As they're folding, they have to fold just right. And you don't want the wrong kind of fusion to happen in the wrong place, and you don't want the folding to get off. So what we see here are some things that can happen because the folding and because the fusing didn't happen quite like it should have. And the first one here is ventricular septal defect. In this case, the septum, that's the layer of muscle between the left and right ventricles, has a hole in it. It's not supposed to have a hole in it. So what happens is that when the right ventricle contracts, it's supposed to send blood out to the lungs. But some of that goes through that hole into the left ventricle instead. So we have reduced blood flow to the lungs, which is setting us up to have an oxygen deficiency problem. The left ventricle, when it contracts, it's supposed to push blood out through the aorta to the rest of the body, but some of it instead goes into the right ventricle. This sets us up with a blood flow inadequacy to the rest of the body. So we have an oxygen deficiency thing because the right ventricle is not sending everything to the lungs. We have a blood flow issue because the left ventricle isn't sending everything to the body. In the process, that oxygen poor blood that came from the right side to the left Some of that goes out to the body, so that further dilutes the oxygen level in the blood. We're also putting extra strain on the right ventricle. Remember, the right ventricle normally was much less muscular than the left, but because it has so much more force on it, as it's trying to push that blood, more is coming in from the left ventricle, it becomes thicker a little bit. So we have reduction in blood flow to the body, we have reduction in oxygenation levels of the blood. That's a problem. The solution is just to go in there and sew those two sides or pieces of the septum together. Sew the hole closed. Problem B, coarctation of the aorta. Right atrium is working, or rather the right ventricle and left ventricle are working fine, no problems there. The problem is the aorta is narrowed. And because it's narrowed right here at the top of the heart, the blood that's supposed to go from the heart down to everything below the heart has a smaller opening to go through, and that raises blood pressure there. So you have blood flow reduced going to the lower body, which perhaps might lead to some weakness there. We have dramatically increased blood pressure in the aortic arch. That's this upper curved part of the aorta. That's also going to increase blood pressure to the head. So one might argue that raises blood pressure in the head to levels that perhaps isn't a safe level, increasing maybe the risk of something like a stroke. The solution for that might be to go in and put a stent in the narrowed part of the aorta to hold it open. Tetralogy of Fallot, the last one here, has a number of different problems. Here we have narrowing of the pulmonary trunk. So the right ventricle tries to send blood to the lungs and has a hard time getting it there. So we're going to have reduced blood flow to the lungs, meaning oxygen deficiency. We have a ventricular septal defect there as well, which further makes this oxygenation issue a problem. But because the right ventricle is working so hard, trying to push blood through the pulmonary trunk, it greatly increases its musculature until both right and left ventricles are roughly the same degree of muscled. This means that the blood flowing from the right ventricle to the left ventricle is much more than it was just in the ventricular septal defect by itself. So over there in A, most of the blood was going from the left ventricle to the right. Here at the tetralogy of Fallot, we've got roughly equal amounts going from right to left and from left to right, meaning we have less blood going to the lungs, more oxygen-poor blood going to the left ventricle, and we have an even more serious oxygen deficiency in the body. Solution here would be sew the opening closed, insert a stent to hold it open. We've got more problems to fix there. With modern healthcare, a lot of these problems are fixable. So sometimes we have babies that are born with problems that are detected shortly before or perhaps after birth. And it seems quite crazy, but it is possible to do open heart reconstructive surgery on a newborn. I know of cases actually where that's happened. And when you get to your medical microbiology experience, if you ask Dr. Beverly about congenital heart defects, she'll be more than happy, I expect, to tell you all about those. One last thing let's talk about here, and that is actually two things. Heart sounds. I mentioned heart sounds earlier just briefly, and that was with the idea that when the valves close, they make a noise. So perhaps you've heard of sounds of the heart being a lup dup, or a lub dub, or a thump thump, or whatever you want to call it. The first sound, the lub, comes from the atrioventricular valves slamming shut. So that was the tricuspid and the bicuspid. When they slam shut, that's the first heart sound that you hear. When the semilunar valves, that's the pulmonary and aortic valves, when they slam shut, that makes the second sound, or the dub sound. The other thing I want to briefly mention here are a couple of things that have to do with heart rate. So some terms. Tachycardia. Tachycardia is an abnormally fast heart rate. So a resting heart rate more than 100 beats per minute is considered tachycardic. That can be from any number of things. If your body temperature is too high, if you're stressed, if you have heart disease, if you have certain drugs in the system, that could do that. So resting heart rate over 100, that's a problem. Mostly because the faster you do something, the more likely you are to make a mistake. In the case of the heart, it needs to do something in rhythm. So the faster you're doing it, the more likely you are to get out of rhythm. Bradycardia is slowing of the heart rate. So this would be defined as less than 60 beats per minute. In a resting scenario, you would be bradycardic. So those of you who are Grey's Anatomy fans have no doubt heard characters in the show talk about someone getting tachy. If someone's getting tachy, that means they're becoming tachycardic. Their heart rate is going up too high. If they are bradying down, they're becoming bradycardic, and their heart rate is slowing too much. Now, just because someone has a heart rate of less than 60 beats per minute doesn't necessarily mean they have an immediate problem. If you look at that individual and they are very physically fit, so they're clearly physically active, what that might mean is their heart is in such good shape that it doesn't have to beat as quickly to be able to keep up with the blood demand for the body. And so that's just called being in good shape. But if they happen to be overweight and clearly not very physically active and have that low heart rate, you might look a little further and try to figure out why, because that doesn't make sense. Hopefully you learned a lot here, and this was all nice and easy to understand information. I'll see you next time.